He's a cornea, cataract, and refractive surgeon at Indore.
Surgery. I have no financial disclosures. So workup is the most important part in planning refractive surgery because surgical outcome depends majorly on preoperative workup. There are certain contraindications which needs to be ruled out. There is little margin of error and patient expectations are very high. So refractive surgery workup includes clinical history, detailed clinical examination and specific tests. So in history, we need to understand what are the patient expectations. We need to ask leading questions to the patients why they want to go for refractive surgery, what is the aim for them, what are the difficulties they face with glasses or contact lenses. If somebody is a contact lens user, we need to know about type of contact lens and last date of use of contact lens. Ask about any ocular diseases like herpetic infection or trauma or even contact lens induced infection. It is important to ask about antihistaminic use because that can lead to dryness, and triptans for migraines which can lead to altered corneal wound healing. If there is any history of squint surgery, that can indicate amblyopia in the type. So it is also important to rule out diabetes and other autoimmune diseases. Ask about any keloid tendency for any other scar in the body, and ask about any major illnesses like epilepsy because if patient has seizure during the surgery, that can be disastrous. And we managed one case with patient was known case of epilepsy, and we had our anesthetic doctor stand by and we managed it nicely. It is important to ask about family history in certain conditions like keratoconus, and ask about patient what kind of sports patient plays and what kind of work patient does, and if patient is habituated for alcohol and smoking, that also needs to be noted. Examination includes visual acuity, uncorrected and best corrected. Apart from that, detailed clinical examination including slit lamp biomicroscopy and dilated fundoscopy is very essential. Refraction needs to be done using cycloplegic agent for both hyperopia and myopia. During clinical examination, be watchful for meibomian gland dysfunction, and because that can lead to worsening of dryness after the surgery and it has to be treated preoperatively. Always do fluorescence staining and look for tear film breakup time and treat that condition according to the tear film deficiency, according to the which layer deficiency patient has. It is important to look for lenticular examination in a dilated state because subtle small posterior subcapsular cataracts can be missed undilated in undilated conditions. Uh, Watch out for high intraocular pressure and shallow anterior chamber, and do a von Herrick method to screen the patient and confirm it by gonioscopy. If patient has shallow anterior chamber and angle closure, then phakic surgery should be avoided. In dilated examination, watch out for lattice degeneration and retinal holes in the periphery. If they are found, that needs to be barrage lasered by retina specialist before planning refractive surgery. Moving on to specific tests, which includes tests for dryness, corneal topography or tomography, anterior segment OCT, biometry measurements, aberrometry, and pupil measurements. Apart from routine clinical examination and fluorescence staining, if you have access to keratograph, do a mebography and look at the meibomian gland morphology. LipiView gives a better detailed evaluation about lipid layer thickness and blink dynamics apart from mebography, and do OSDI scoring to understand what kind of symptoms patient have as a subjective measurement, and you can treat the dryness according to all these parameters. It is important to do corneal topography before planning refractive surgery. It is the most important investigation to screen refractive patients. We have Alcon oculizer, which is based on Scheimpflug imaging technology, which is just like in Pentacam. So this is the normal topography report of a patient. It is beyond the scope of this presentation and instruction course to go in detail about each and every parameter of the corneal topography report. But it's important to look and screen at the area of posterior elevations. We need to look at the posterior elevations, then anterior elevations, then look at the corneal pachymetry and keratometry values. Here everything appears normal and this patient is clear for refractive surgery planning. And also look at the Berlin Ambrosio enhanced ectasia display, which help us to look for any ectatic conditions like keratoconus. So this is another case where you can see there is significant posterior as well as anterior elevation, and the same area has less pachymetry and there is a corneal thinning, and keratometry values showing steepest in that area. So this is the case of keratoconus, which is also visible in the Berlin Ambrosio and ectasia display with significant anterior and posterior elevation difference between normal BFS and enhanced BFS. This is another case where elevations are not that significant, patient has borderline thickness, but there is a steep cornea. So microkeratome MK LASIK should be avoided in such conditions because that can lead to high chance of buttonholing in such cases. If you have access to femtosecond laser, do a flap using a femtosecond laser. If not, then you can go ahead with the PRK surgery in this case, and we planned a PRK surgery for this case and patient did very well after the surgery. Pupil measurements in photopic and scotopic conditions is most important to document, because if your scotopic pupil size is larger than your ablation zone, optical zone, then it can lead to glare and halos at night for the patients post-operatively. So aberrometry profile is also most important in refractive surgery screening patients. So there are various aberrometers available in the market. I'm going to talk in brief about this eye trace by Hoya. So this is the report and summary given by the Hoya eye trace machine. You can see how it is giving a detailed report about lower order aberrations and higher order aberrations, including spherical, coma, trefoil, and other optical aberrations. And you can choose the refractive surgery according to the level of aberration profile. If patient has significant high spherical aberrations and coma, then it is important to go for either wavefront guided or topo guided refractive procedure. This is another case where patient is complaining of blurring of vision and topography appears more or less normal, and you can see that the aberrations induced by cornea is not much, but the aberrations induced by internal optics, which also include lens and vitreous body, it is high. And the issue here is a dysfunctional lens, and patient is seeing blur because of that, the same. It is important to look at the corneal endothelium if you are planning a phakic IOL surgery, and if endothelial cell count is less than 2000, phakic IOL surgery should be avoided. Anterior segment OCT is important to look at the internal anterior chamber depth, which includes measurement from the endothelium to the anterior surface of the lens, which should be more than 2.8 millimeter. And post-operatively, it helps to look at the vault of the phakic IOL, which should be between 200 to 800 microns. Biometry measurements are also important in planning phakic IOL surgery. So if you have a IOL master or whatever biometer you have, do a complete biometry for both the eyes. Look at the white to white measurement given by the biometer and compare it with the manual white to white measurement using a digital caliper. This is most important in deciding the size of the phakic IOL, because that is the most important part of the planning of phakic IOL surgery. Undersizing and oversizing of phakic IOL can lead to disastrous complications post-operatively. This is the algorithm for choosing a refractive surgery according to the screening profile of the patient and what kind of findings you get while screening, designed by Dr. Rohit Shetty and team of Narayan Netralia. I follow the same. It is available online. You can have a look at it. Thank you so much.